I wanted to know what each of the women on the panel thought of the movie. I wanted to know your initial reactions and what you thought. And Dr. Klose as well. Actually, I'd like to hear Dr. Klose's answer first.
What did you like about it?
I thought it was
You
very
use the mic?
truthful, and I liked it.
No, I think you just not.
You know, to the point, I've been doing VBACs for 25 years, and I think a lot of the different viewpoints were really good, having as many people giving their viewpoints, particularly like that one female doctor that, there we go. The one was kind of relaxed, and, you know, she was really interesting, and I think their perspective and the different perspectives is very helpful, because there's certainly a lot of opinions about VBACs, and you know, and I also saw a lot of people talking about the influence of hospitals, the influence of insurance companies on VBACs, and believe me, they're real influences. Just here in Reno, we used to have a rule that, you know, you had to be immediately available if you're going to do a VBAC with a patient in the hospital. And immediate available meant 15 minutes. You had to be available to be at the hospital. The hospitals have most recently, both hospitals that deliver, have changed that you now have to be in-house in order to do a VBAC. So that has kind of put a wrench in a lot of doctors' practices, and myself and my partner, you know, do VBACs, but we also take call with another group, and some of the people in that group don't do it. So there's a lot of issues. I think it's a healthy thing to do. When I was in training, we were one of the trial sites for VBACs, and we used to do VBACs for anybody that had as many transverse incisions as they wanted, or even one low vertical. And so we had a lot of experience with VBACs. So I'm all for it, and I really thought the movie was to the point and gave a broad range of perspectives on what people thought about it.
Well, I'm pleased to see that this discussion is going to become more mainstream, because of course anything attached with Ricky Lake and the business of being born will make people start talking. And when you start talking about how you want to birth your baby when you find out you're pregnant and not at the hospital tour at 36 or 37 weeks, you're going to have a better birth. So I was also pleased to see that there's apparently more movies coming in this series. So the more we can talk about what's going on and what's not going on, there's fewer surprises at the end. So I felt like the information was sorely needed. We need to be talking about this more and more, not less and less.
One other thing, I'd just like to have a copy of that movie, so when people come in and want VBACs, I can hand it to them and say, hey, take this home and bring it back next visit.
Okay, I'm going to rain on the parade. I think it's good that we have a specific media piece that's about VBAC, but I found it very problematic. I found the unchallenged language around VBAC extremely problematic. It's not a successful VBAC. You plan a VBAC and then you have a vaginal birth, or you end up with a repeat cesarean. The moment you start talking about successful VBACs, then what is a repeat cesarean? It must be a failure. I also find it very problematic that we're talking about trial of labor. Since when do we put women's uteruses on trial? I think although I was going to say that we don't talk about trial of labor in women who have not had prior cesareans, but now we do, which implants the idea that this is I'm a writer, so I'm very sensitive to the nuance of what language says. So I found that continual repeated, that, just in the use of the language, that this is a difficult and not very likely thing. I found it, a lot of the experts who were giving so-called factual information about VBACs and cesareans, it wasn't accurate information. I wish they'd had, frankly, I wish they'd had me, because a lot of it was just, it wasn't the accurate information. I'm very pleased that there was this cadre of progressive doctors. There was some information about, that really is the woman's body and she has the right to make these choices. But I really didn't hear the challenge that should have been made on the whole idea. I mean, the American Congress of Obstetricians and Gynecologists actually has a code of ethics, and one of the items in the code of ethics that says where there is a conflict of interest between the patient and the doctor, it must be resolved in the best interest of the patient. And I would argue that not wanting to be sued is a conflict of interest, and it is not being recognized as such. So while I think there was a lot to be said for that video, I really did find it problematic to the point that there were points where I didn't know if I could stay through it. Mm-hmm. Well, but I don't think the solution to that is to just sort of, cluck over it. I do feel that most doctors, even obstetricians, even progressive obstetricians, and certainly doctors in other fields will, but let's look at the obstetrics. If the argument for doing things in a particular way is so that you don't get sued, there was a 2009 survey of ACOG obstetricians who found that 90% of them had been sued at one point or another. So as a strategy, it's not working. And as Dr. Michael Klein said a number of years ago at a talk, you're going to get sued anyway, so you might as well do the right thing. So I think that's a factor that we really need to start looking at, and we just can't shake our heads and say, yes, but if something goes wrong, there's going to be a lawsuit. You're right, there is going to be a lawsuit, but the answer to that is like, well, we should have done a cesarean sooner. I think I think part of the reason, I'm aware of at least one case some years ago, this was actually the case. Some lawsuits arise because we don't have a system that guarantees that babies that are born with handicaps or various problems after a birth are going to get the money they need to be looked after properly. The only way to get that money is to sue. So there's something where I'm aware of a case of a friend of mine who's an obstetrician a number of years ago where his patient said to him, I know you didn't do anything wrong, but I have to raise this child. There's also the human instinct that when something goes wrong, if it's horrible, we would rather think that somebody else is to blame, this is human, than to think that it was just a lightning strike out of the sky. It could happen to anybody. It could happen again. Because if you think somebody did something wrong, then you think it can be prevented. I also know that another way to reduce lawsuits, not obstetrics particularly, but I think this was at Johns Hopkins, where they changed their policy. And they said that if something goes wrong, that's a mistake made, is that you, as soon as it's discovered, you apologize profusely and you tell the patient what you're going to do to try and make it right for them and also to prevent it from ever happening again. And their lawsuits were like cut in half. So there are lots of other strategies rather than just saying, well, this is just the way it is and we just have to accept it. Which isn't to say I don't have a lot of sympathy for the position of doctors who are caught between this rock and a hard place. But I think it can't become a reason to maintain the status quo.
I really appreciate Henci's voice here. And I have to give kudos to Abby and Ricky for doing an entire film around VBAC, because I think it's really important that we're talking about this. And what I appreciated the most about the film was the continued emphasis on taking personal responsibility for our births, for for what it is that we decide that we are doing with our bodies and our babies and our births. And I loved how that was exemplified by the final home birth, the HVAC story at the end of the film, which I found incredibly moving. And her commitment to herself was laudable, and I'm so glad that they included that story in the film. It's an example to women everywhere, no matter what your scenario is. Ultimately, that's what we're after here in the U.S. is that we, and globally, is that we take responsibility for what it is that we desire, and that we make our desires known, and that we, just that we're taking responsibility for our births.
I have to say it's a little weird to relax. The first question, I think, was my first impression of the film, right? Because now, obviously, I have all these other thoughts. So my first impression of the film was very emotional. I mean, I think I said to everybody afterwards, I could have buckled over and cried for half an hour, numerous times in the course of the film. Which to me says that healing is taking place by this film existing. Which just throws me from the tip of my toes to the top of my head, to my fingers. If there's anything I feel like I've seen since I've started looking at this more closely is that it's a really tangled web. And the only way I think we're going to come up with solutions is to start talking and presenting what we think and how we think about it as a collective. And Ricky and Abby making these movies is, in big part why any of us, I think many of us, can even be up here talking about what we're talking about right now. So that was my first impression, is that we need more conversation, and their fearlessness to have and present what they presented is helping every single one of us heal. So thank you.
I've got a question. This is kind of nerve-wracking. Okay. My wife helped found the Truckee Meadows Birth Network here in Reno, and she is one of the most passionate women about this subject that I've ever personally had the opportunity to meet. So I want to thank you for having even more passion, it seems, to be up there and supporting all of this. I, on the other hand, honestly and somewhat regrettably, have been apathetic as a father, and in terms of supporting my wife in this early on. I've become more and more passionate about the subject myself. In fact, I even found myself talking with a coworker about this yesterday, and I work around a bunch of guys that are technicians, and they don't talk about birth, you know? My question is, I was really hoping to see this room packed full of people from Reno, and I'm saddened that more people aren't here. What are your opinions and ideas about how we approach the public who are seemingly generally apathetic about all of this? It just seems like people just don't seem to care, and it hurts my heart to think that that's really what's happening. People just don't seem to take this seriously.
So I think we deal with this all the time. I mean, every day, right? I have to wake up and go, what am I doing? And really, honestly, what I've come to for myself is that the healing is so deep. Stephanie had this great paper she wrote that helped me language it, which is the difference between birth hell and birth heaven. And that those of us that know that birth heaven exists are like singing it from the treetops, like, birth heaven, come join us. And the people that only think there is birth hell are like, what are you talking about? So I'm just gonna keep singing, is what I've decided. And the people that start wanting to learn about it show up. I'm happy that all of you are here. Yeah. And that this much momentum was created for this event. And I think that that is exponential. I think everything will continue to happen exponential, this idea of the 100th monkey. And as Dr. Chris John Northrup said in the Ecstatic Birth Telesummit, it's never crowded at the beginning of a movement. Yeah.
I really want to acknowledge the fact that you're here today, and what it's going to take is each one of us leaving tonight and continuing the conversation in whatever way that feels comfortable to us. You know, for me, I tweet and I do a lot of social networking around all of this. I've been doing it all night, listening to Henci and taking pictures and uploading them, and so there's a lot to be said for what's possible with social networking and blogging. If you blog about what you've experienced here tonight and your thoughts about this film, and hopefully everyone in the audience is going to see all episodes of The More Business of Being Born, and let's just keep talking and sharing and talking to our nieces and our daughters and our sons and everybody, our aunts and our uncles and our grandparents, because there's a change happening right now, as we can see with Occupy, the Occupy movement, and the birth. What's happening in the birth world is right there with the Occupy movement, and that's why we're here tonight. And so, my charge to Tiffany and to the entire birth networks that are represented here is, let's keep doing this. Like, keep these events happening. Maybe not quite as large. Maybe we can work up to filling the house here at the Pioneer maybe in a year or two. But let's keep doing these events, and let's keep screening these films that are continuing the conversation.
I don't know. We can go in order.
Okay.
I don't have a single patient hardly comes to my office that doesn't say, well, I saw that on the internet, and the internet seems to be the key in the current generation.
Apparently they still can't hear you.
Still can't hear me? How's that?
There you go.
So the internet seems to be the key, because almost every patient I see in the office is always saying, I saw this on the internet, what do you think about that? So I know you do Facebook and things like that, but somehow getting it onto the internet, when it comes up on Yahoo, the 44 different things that are news for the day, that's where it's got to go.
I think there is a shift happening, because I actually have lived the arc of this movement, is that I got involved in. I started in 1980 when the cesarean rate was on the upward arc, and at first there was some concern about, oh gosh, the cesarean rate is 15%. Wow, that's so high. And then it all disappeared, and those of us who were sort of birth advocates and for birth reform were shaking our heads about, where is this all going to go, because nobody seems to care as long. And yet now there's this huge upwelling again of younger women who are involved. And again, I would agree that it is the internet and the social media, because they make getting your message out incredibly cheap. And I'm also seeing a shift in mainstream media articles through the 90s, the late 80s and 90s. It was the idea that we should be doing fewer cesareans was kind of the straw man. It was all about, cesareans are terrific. And now you are starting to see the articles on maternal mortality rate on the rise because of C-section. So there's been even a shift in the mainstream media. And personally, although I think that was the question you answered, but I'm not sure it was the question that was specifically asked. How I keep going personally is the quote that I use from at the bottom of my emails, which is from Pirkei Avot, which is one of the books of the Talmud called The Wisdom of Our Fathers. And it's that you are not obliged to complete the task, neither may you depart from it, which basically says, I don't have to fix everything. It's not up to me to make it all better. I just have to keep hoeing my pea patch and, and see what happens next.
So I'm so glad you're here, and I'm so glad you asked that question, because I ask that question every day. How can I talk to a stadium full of women? Mm-hmm. And lo and behold, the universe answered me, and the people from Complete Idiot's Guide called me and asked me to write a book, and I immediately refused because it had idiot in the title. And no offense to you, sir, but I've had a lot of doctors, when I transport my clients from a home birth, call me an idiot. So it just didn't feel right.
Oh my gosh.
However, when I stepped back from it and said, wow, maybe this is my football stadium, it just doesn't happen to happen in a stadium. Mm-hmm. So you have already done the first step. You talked to your coworker, and how courageous did you have to feel to do that? And yet that's what we do every day, is we're courageous enough to say, have you thought about having your baby at home? Have you thought about staying home longer next time before you go to the hospital? Have you thought about changing your doctor since you didn't like what happened last time? You know, the definition of, what is it, insanity is doing the same thing over and over and expecting a different result. Totally. So talking to people is how you fill the stadium, and it's painfully slow. But each one person, he's going to now feel brave enough to maybe talk to somebody else, and it might take him months to do it. But then, when somebody else brings it up, you're going to become the expert in his eyes because you talked to him first about it. You are brave enough to do it first. So be brave every day.
To fill a stadium, you have to have a winning team.
Well, yeah, that's true.
I just want to pose a question to everybody here to sort of put things in perspective, if you don't mind. Is how many of you sitting here had some experience of emotional processing or healing that you went through that helped you get to this place? Right. So we're talking at least half of the people out there. So I also want to just speak to the fact that that's what's going to happen for many people to be in this room. And for us to have the openness and spaciousness and compassion to allow each individual to heal whatever it is that's keeping them out of this room.
Exactly.
While we're talking to them.
That was part 2 of my note, exactly. Every empty seat in here is somebody that is not ready to revisit their birth.
Yeah.
Because I do home births, because I do water births, because I have some very nice laborers. I have some that have given me a lot of gray hairs, but every now and then it all comes together. And what happens to those women is nobody wants to hear their birth story because it was nice. There's like, you get this badge of honor in the United States. I had a 97-hour labor and they had to take the baby out my nose. Okay, you win. It doesn't count if it didn't hurt or they didn't, 97 people had to be in the room. So when we ask the birthing population to compare their experience to other women's experiences, sometimes that's too hard. I don't want to revisit it. Don't make me think about it. Don't make me watch a movie about a cesarean. I had one. Please don't make me look. So for every empty seat, there's probably 2 or 3 families that would like to be here. They just can't quite do it yet. They haven't gotten mad enough. Marston Wagner said that. Mm-hmm. The women of the United States have not gotten pissed off enough to change what's happening in hospitals over and over and over. The policies and procedures that this layer that everybody in your arena has to work with in order to play the game. I play by slightly different rules because I'm a home birth midwife, but I still have to play by rules. And this shift, we are in transition. I keep threatening to add a page to my website that says, this is going to piss you off. Which maybe a blog is the same thing, I don't know.
And beyond just addressing birth trauma, are the relationships to sexuality and intimacy and going into really deep oxytocin states. I mean, it's just lots of healing to be done. And each one of you that are here did that. And so thank you.
Thank you, guys. And we have a question right here. Sorry. This question is sort of for Henci. I want to know if you know the difference between the European populations and our own as far as C-section rates in relation to how healthy of a population we have. In other countries where the C-section rate is low, do you think that those people are a lot more healthy? The United States, the population seems very unhealthy compared to other parts of the world, and I think that I don't see a shift, actually. I see a shift the other direction. I work in labor and delivery. I have been an RN since 1983 in labor and delivery, and I have never seen so many C-sections, but I think it's because of how poorly people are taking care of themselves when they're pregnant, and they have a lot more hypertension and diabetes. I've never seen so much in my whole life than we have right now, and people feel free to gain, 50, 60, 80, 90 pounds during pregnancy, thinking it's perfectly fine. And I feel like part of our C-section rate is due to the general unhealthiness of our population compared to other parts of the world. What do you think about that?
There's I think it's on YouTube. It's GYN Dr, you also saw in this video. And there's a YouTube video called Birth by the Numbers. In it, GYN Dr, who is an epidemiologist at the University of Boston, he's a professor, dismantles all of the common reasons that are given for the rise in cesarean rate, such as that women are older, women are fatter, babies are bigger, and basically shows how the cesarean rate has gone up in every segment of the population. As far as European countries go, again, one of the, this is not my area of research specifically, but the cesarean rates are all over the map in Europe. But it's also incorrect to think that in countries where there's low cesarean rates, that they have no unhealthy people in those countries. They still do better than we do. But I think you've put your finger on something, is that increasing the number of interventions around birth is not the solution. Right. The solution, as it has always been for reducing morbidity and mortality, is our public health and social issues.
Education. Mm-hmm.
But it's more than education.
I have patients that know the right thing to do but don't care. Like you said, they're apathetic, some people.
Well,
and they just don't think it's important.
But then there's a deeper question of why don't they care? I mean, so let me pick an example of a conference I was at years ago, which had a young black woman on the panel, where a low-income population may be chided for not turning up for their prenatal care visit. Sort of like, shame on you, don't you know that if you don't get prenatal care and that this is bad for you and your baby? And she pointed out that for the low-income woman who has another child who has to take 2 buses to get to the hospital, then gets to sit in a waiting room waiting to see somebody for 15 minutes who treats her disrespectfully, it's, in other words, there's a whole context where there are, like you said, it's a web, there are no simple answers. I would say that it's an unusual woman who is completely apathetic about her and her baby's well-being. So if you have one who is, the next question is, how did she get that way and why? And which makes it a much more complex issue, for which cesarean sections or more interventions around the time of labor is not the solution.
It's more trauma.
Right.
Yeah.
Well, but then again, everybody wants epidurals now, and everybody wants a lot of info. It seems like they welcome the intervention, and they're surprised when those of us that advocate the opposite, and they, because all of their friends and they, people they talk to on the internet,
right. So
this is the what to do.
We do have a culture, but here are some pieces of that problem that I'm aware of, and other people will be aware of others. For one thing, women are not getting informed consent around epidurals. They're being told there are no problems with epidurals. You can read newspaper articles in which I have some, I keep these things, in which statements are made that epidurals don't slow labor. They don't have any problems connected with them. So obviously, if you're going to walk up to a woman and say, you know what, you don't have to suffer in labor because we have this wonderful technique, it doesn't cause any problems and it will relieve your pain, I'll sign up for that. So that's one piece. And the other piece was enunciated by Judith Lothian in the book Pushed, which if you haven't read it, it's a fantastic book, in which Judith Lothian points out that I don't know who the you was that she was talking about. She's a professor of nursing. You blame women for wanting epidurals, but you've confined them to bed. You've given them Pitocin to increase, the pain of their contractions. You can't even you haven't given them any other options. So don't be surprised when they want an epidural. So again, I don't think it's a straightforward, simple, magical solution. But if you start pulling back and looking at the pieces of the puzzle, is why do women want epidurals?
Well, they're afraid of pain. I've had people come in and we've offered showers and walking, and they do not want to have any part of that. And as soon as they start feeling pain, they're genuinely surprised that it hurts.
Right. So there's, women aren't taking childbirth classes.
Yeah, and they're
going to die in a minute. We don't let her ask you questions.
Women aren't taking childbirth classes anymore.
And then the anesthesiologist, they try to explain the complications, and I certainly do. And they don't even want it. They stop you right in your try. I don't even want to hear it. Just do it. I don't even want to hear it.
Well, hold on, come up to the microphone before this one needs an epidural. Okay. I can't have this under my watch, so please.
Well,
all right.
if you are trying to slow women down from getting epidurals, I have to say that that you may be you are not the average.
Oh, I know that. And that's why we're here.
Right, and that's why we're here. So whatever support that we can give you, I would love to do that, because we need to clone you.
Yeah.
Hey, it's so nice to have you guys here. I'm so excited. I am from Norway, Europe, so I can give that little tidbit a little bit. As I understand, at least about 12% C-section rate or less. Some of it is because of socialized medicine. We are not so happy, and there is no insurance to cover. So that, politically, I guess would just automatically lower the rate, right? Because there's no money, there's no win-win, other than what's best for mom, what's best for the baby.
Aren't the majority of your patients taken care of by midwives also?
Yeah, yeah, most birthing centers, freestanding birthing centers, yeah.
Thank you.
I just wanted to briefly back up what the last nurse said. We work in a high-risk labor and delivery facility, so we do have in-house doctors, anesthesia, level 3 NICU. A large portion of our population comes and wants an epidural before the induction is started. They're coming in for their elective inductions that their doctors have probably somewhat pushed them into. Most of them, they want their epidurals, they want their inductions. So we are coming from kind of a jaded place that we see overweight, unhealthy people day after day that, like I'm saying, they want their epidural, so they are stuck in bed, and there's very little we can do at that point when they're in labor to veer them the right way. So.
I mean, you're not going to fix the problem at the point that they're walking in the labor, the labor room door.
Right.
It's all kind of preset. But I can tell you, based on my personal experience with my daughter-in-law, that one progressive obstetrician can change the way an entire department functions, because that happened at Kaiser Santa Clara, and she had a very difficult induction. It was like a 36-hour. She was not induced at 41 weeks. At 42 weeks, it seemed pretty reasonable.
Right.
She ended up with like a 36-hour labor. She ended up pushing out a 9-pound baby spontaneously, posterior. She did have an epidural. It was a very considered choice because she really needed to rest. But the way her labor was handled, turning off the pit, letting her rest, putting her back on the pit, giving her time to push. I mean, there was such respectful treatment that I was like, it was a perfect example of a difficult hospital birth where all of the interventions were necessary, they were respectful, there were informed decisions made, and resulted in a vaginal birth to a healthy baby, which I think would have been a preventable C-section almost any place else. So I think it's the internal, I'm going to be really, subversive here. And if there are like-minded nurses and they band together, but I think what often happens is that the nurse who kind of sticks her neck out and is different from the rest ends up running into a lot of trouble.
Right.
But if there's enough of you, that I think real change is going to be made from the inside.
Well, thank you. That was going to be my question to the rest of you. So at this point, the late stage in the game when we're seeing patients, what else do any of the rest of you think that we can do to help encourage patients to help themselves, basically?
Can I ask, do you feel a sense, it's not the population I generally work with.
Right.
Are you feeling a sense from these women that they feel defeated already?
I think it depends. I mean, I hate to generalize a lot of them together. We have our low-risk side, which is run by our midwives, our high-risk side, which is... Oh, I'm sorry. We kind of have two separate populations, low risk and high risk, and so, the high risk are kind of their own entity, but it's kind of a hard question to answer.
Yeah, I'm just wondering if, the empowerment piece, like helping that, I think a lot of, it made me think too of what Jenny was saying about those of us that have awesome stories.
Right.
Often are nervous to share them because it could be emotional for the person we're sharing them with. So for us to have the tools to share anyway and let people emotionally process, and then you can start to feel those morsels of people's empowerment and like follow it. Like, oh, you feel empowered about this, let's go with that.
Right. And I think, again, the two of us nurses from my department that are here are pretty good at that. We like supporting patients in labor. But as far as the empowerment, I mean, we work for Kaiser. It's a huge HMO. They have, this much time in their prenatal visits. And I think that's where the empowerment is lacking, is they don't have that support prenatally. So again, it's like, what do we do at this point short of find another job?
And the other thing, and this I read in studies, because I don't have the personal experience of it, but if you're working a busy intrapartum unit, it all goes a lot more smoothly for everybody if women are receiving exactly the same care. They all get their epidurals, and you monitor, and then you go in when it. So there's a systemic obstacle. That's part of the problem as well. It's very difficult to individualize care, and the woman who hasn't had an epidural demands a lot more in time and effort. But I'm thinking maybe they could think creatively. I think this is where doulas could be a big help.
Definitely.
I was just going to say, the almighty doula. There's a massive opportunity here for doulas, because I was just speaking with Tiffany last night that there's an opportunity for a relationship with a doula that is not possible with an obstetrician or a midwife. And so the doulas, I feel, they're a real bridge to, they can, and particularly one of the pieces that I think is so important that I think that more doulas want to consider is how to reach expectant parents sooner and to even have more than 2 to 3 prenatal visits. And to really, because the other thing that I think doulas represent is not only do they have this opportunity for a different relationship, but it's a relationship that looks at the full spectrum of being, the mental, emotional, spiritual realms, which most midwives and doctors don't have time for.
Sure.
So there's a huge opportunity there.
Thank you.
I can't help but add that I think for every woman that comes in, you have to start with where she is and what she wants at that point, and just sort of follow her lead, because I think the thing that's most empowering is the shared decision making, and that she's not feeling pressured in any direction, whether it's not to have an epidural or to have one.
Yeah. They did with us. It's more like they just decided that, they don't know what they expected, but it's not what they expected. What hurts?
Yeah, that actually is a hole that's turning up both is mismatched expectations. So I think there's an educator component there.
Go ahead.
This is kind of a personal question for me. I have 3 healthy sons, and we want to have one more. But I have had 3 C-sections. So what are your thoughts on that as far as having a VBAC after 3 C-sections? Risks, advice,
Well, like I said,
my odds.
where I trained, we were allowing people to have as many C-sections as they want and still do a VBAC. I still stick to that rule. I mean, preferably 1 or 2, but I've seen people with 3 and 4 and 5 C-sections and still do a VBAC. A lot of it depends on what were the reasons for the first one, or the others just repeats.
Yep.
So recurring type of things. But that's a personal conversation you probably have with your doctor.
I just feel like I'm totally taboo to all obstetricians. I received a lot of negative feedback and just no support at all.
You haven't found the right one.
Yeah, I mean, the standard thing is
So-
like a low transverse C-section. Was that
Yeah.
the first one? I mean, if you had a classical, forget it. You're probably not
Yeah.
going to get very many obstetricians in the entire country to agree to that. But, with multiple transverse ones, I don't see that as a problem.
So you do them,
Yeah.
because you're the first that I've heard. Yeah, can I have your card?
The first question, though, you need to ask yourself now that you have this information is what is it that you want? If you're going to have another baby, how do you want this birth story to come out of your mouth after the fact? What do you want?
Well, I want to have a vaginal birth in the hospital. That's what I want.
I want more details.
Oh.
You don't have to say them here, but you sure need to do the homework of what is your birth.
The story that was read in the beginning petrifies me of being yelled at by the doctor, and I don't know if I'm strong enough to withstand that. I mean, I would need support from the doctor, and that scares me, the negativity from the nurses and the doctors, and because I would want to do it in the hospital, not at home.
Yeah.
But what else?
I just want to say that, I was really moved by when Tiffany read that story as well. And I don't think that any woman, no matter what her decision, deserves to be spoken to that way, ever.
No, of course not.
So disturbing.
Yeah.
So, we just have to do everything in our power to alter that in terms of how we're relating to each other.
Yeah.
In the Western medical model of care and in the midwifery model of care, both. We really have to look at how we're talking to each other because it's just not okay.
Okay, thank you.
Hi, I want to know if there's any information that separates C-sections. I hear stories all the time in the grocery store, wherever. I'm a midwife, and people just love to tell you their birth stories. So I hear it all the time, and one of the stories that I always hear is, I was in the hospital and I stopped progressing, and then I got Pitocin, and then suddenly I had an emergency C-section. Are there numbers out there that show us with C-sections, the ones that happened without interventions, the ones that didn't follow Pitocins, the ones that didn't follow that typical story that we've heard a million times of everything was going fine and then, things were slow, which generally is
The cascade, as they call it.
right. The story that we all hear. Henci, are there statistics that tell us that break the C-section numbers down?
I'm not absolutely clear on what you're asking. Could you try saying it a different way?
It sounds like to me what you're trying to ask is there a delineation being made to a level of intervention? Like how many C-sections are happening without,
As a result
so
of?
fully natural, unmedicated, and then it goes to a C-section versus the cascade effect where Pitocin is administered, epidurals are given. Is that what you're asking?
That's exactly what I'm asking.
Well, but the thing is, the most common reason to do a C-section in a woman who hasn't had one before is for a non-progressing labor. Now, baby won't come out is a very subjective definition, but you can't tell which is the chicken and which is the egg in the sense of if the labor wasn't progressing, at what point was Pitocin introduced? Because that's a reasonable thing to do with a labor that isn't progressing when you've tried other stuff. So, but there's no way to tease out. This is one of the I have another talk called The Limitations of Evidence-Based Medicine, which talks about things like the fact that human beings are involved here means that there's a whole context that doesn't get captured when you do a study. So the real question you're asking was, in that woman's case, was it appropriate to introduce Pitocin?
Yes, so.
Because obviously in some cases it is, and in some cases even after you do that, the labor still doesn't progress for whatever reason. And the woman ends up with a C-section, but in far too many cases, failure to progress is really failure to wait.
Exactly.
I do know that it's very clear that the standards to which we hold women as being sort of how you're supposed to progress have been shown to be not useful, not valid, and harmful.
Mm-hmm.
So At this point, you know, if I ruled the world, we need to take a giant step back. We don't even know what the norms are.
Yeah.
So if we don't know what the true norms are, how do we know when there are deviations from those norms in which it would be better to take an action than it wouldn't? And that's just like this, we just don't know. I mean, there's a recent systematic review out of giving oxytocin early versus late. When well, that's Pitocin is the trade name. It's oxytocin. Okay, well, we can debate that point. But whether giving it early or late is a good idea. And what the reviewer, the lead reviewer, said was, it turns out that it didn't change the C-section rate whether you did it early or late compared to not giving it at all. So he said, actually, I have a quote from him from the newspaper article, we've been giving oxytocin all of these years and it actually doesn't work. I mean, the point of giving oxytocin is to reduce cesareans. So we really have a much bigger problem, of which you asked a little tiny question, is we don't actually know when we should be intervening and how we should be intervening in an effective fashion when we do.
Well, how about this question, Jennifer? Do you know how many of your births have ended in cesarean?
No, I don't know exactly.
Yeah.
I can tell you that I have a less than 1% transport rate.
Well, so that tells you something.
Well, transporting, though, doesn't automatically mean you get a cesarean.
Right.
So what I see is that when I have clients that we end up going to the hospital and we do not have failure to wait, sometimes the client is saying, can I go to the hospital now? It's been 3 days. You know, I'll start my own IV if fit, thank you. We've done everything we know how to do in the midwifery model, which includes a wide variety of complementary medicine. And it becomes clear to me in my experience, what I know, and we only know what we know, is that this baby's probably coming out by cesarean. But here we've had this huge chunk of time, and that varies from woman to woman, that there's been no threat of artificial time frames or medication, or you have to be in this position, or we have to put you on the monitor. There isn't any have-tos. We've let her do whatever her body is telling her to do. And when we go to the hospital, I see then this cascade of events becomes the saving grace for this woman to have no doubts for her next birth. Because now they're going to say, okay, you're wherever they are in their labor, and she's going to go, right, I've been here forever. Please help me. So usually they start with Pitocin, something to encourage the labor pattern, which then often invites the epidural because the Pitocin changes how the contraction pattern actually works. So still everything is her decision. Do you need some relief? Yes, I can't take this anymore, and I'm only X centimeters along now. So now that the epidural is in, they can really turn the Pitocin up to get that effective contraction pattern going. And usually what happens is it becomes clear that for one reason or another, the baby is not going to be born vaginally. They are going to take this woman back to the OR. But what has happened now is this woman had an active part in every intervention or assist, however, I see it as an assist at that point. Here's the next step that the hospital can offer you. Here's the next thing we can do, so that when she goes back to the OR, she knows for sure that a surgical birth is the only way her baby was going to come out. So there's no coulda, shoulda, woulda that she has to heal from or process or deal with for the next birth.
But what you said was less than 1% transfer, and less than that ends in C-section. And that's out of, you said, 900 births?
But I cheat. I do water birth all the time.
Let's hear it for water birth. And nobody asked me, but I just want to say that I think that's such an important part to bridge the gap between how we view the home birth side and the medical side, that it comes down to being empowered and to being a part of the process. And if it does end in C-section and you've been a part of that process, you're not going to Tiffany to have to deal with birth trauma after it. And I think that's important for me, for the whole community, to understand that that is such a key component of this with all these questions that people are asking that comes down to your choice and you being empowered and knowing what your choices are, which I think is the whole point of this, the movie and all of us being here to begin with. So.
The last question I would like to ask is, can we have the cesarean rate for our state, for Nevada? I live in Tahoe actually, but I'm curious what the C-section rate is in Reno, in Nevada. Does anyone know that?
Ooh, now you all are on the spot.
Okay. Okay. 40%. Okay. 40.
An unofficial number. 40%.
All right. I can tell you that at Renown, I work as a labor and delivery nurse there. We average about 33 to 34% a month cesarean rate. That's our average, and they post them so we all are aware. But I have a couple questions. First, does anybody happen to know how many doctors in Reno will actually offer a VBAC? Will actually say, yes.
I don't know the exact number, but I would say probably less than 50% of the docs are doing it. And the large part of that is the hospital driven, you know, now you need to be in labor, holding the patient's hand at all times, you know, whereas 2 years ago, you had to be immediately available, which meant 15 minutes. And that's a huge difference to being, you know, present in labor and delivery because of the timing of these things. You know, you got 30 patients in your office and your VBAC patient walks in the door in labor, and now you've got to, you know, send everybody home. And yeah.
Yeah. Are you interested in trying to change that policy? Because there's no evidence behind it.
Oh, I totally agree, and it's totally the hospital, and you know, and I wasn't part of the process of making that, you know, decision.
And then also looking at the hospital, I mean, just the hospital in general. Again, at my facility, we deal with high-risk pregnancy, and on our floor, we have 2 operating rooms available, an anesthesiologist always immediately available, and there's always at least an OB/GYN that's qualified to do surgery inside the hospital. And yet, so many of and so many docs in our area are still you know, going away from it, you know, going away from the VBAC because they aren't immediately available on the floor.
Well, at Renown, you do have 1 doc available 24/7.
All the time,
yeah,
correct.
Because that's because of the pregnancy center, which I did for 23 years, haven't done it for the last 3 years. But, you know, most of the other private, you know, physicians in town can't afford to live in labor and delivery like the docs do in the pregnancy center. So at St. Mary's, there's no in-house obstetrician. There's always on-call physicians, and you try and do the best you can. But you know, I would much prefer, you know, going back to the old rule of 15 minutes, you know, I can do a VBAC and I can get a baby out in 60 seconds if I have to, but, you know, just the constraint of, you know, having to be in-house to do a VBAC to me is just restraint of trade at this point.
And then last question is, I know that, like we said, a lot of docs are getting away from it. You as a doctor offering VBACs, you know, if you're not on call and you are at your office and you're not able to be there, and you have a patient that you've seen throughout her whole prenatal care, and your whole plan of care have been, I'm gonna go into labor, I'm gonna VBAC, blah, blah, blah. You're not on call. There's nobody there. That changes up her whole plan of care, everything that she planned throughout her whole pregnancy. How does that make you feel as a doctor, knowing that everything that you guys have been talking about and doing throughout your whole visit, everything just changed? It all just went right by the wayside.
Well, if we have someone that we've told we're going to allow to VBAC, me and my partner both do them, correct, that we would say, okay, you know, we're going to come in, we're going to do it, even if the doctor that's on call for us isn't going to handle it. So we would, you know, take care of our own patients.
Okay, perfect.
We're going to take our last question right here.
Hi. So my question is actually a little similar in that the change that has to happen from within is very much real, but what is the change that can happen from the consumers and from the mothers and the families that are birthing in these hospitals that aren't allowing it, and with doctors that have such restrictive rules that it basically, unless the stars align, you are not going to be able to have a VBAC? What are the things that we can do to affect this change, and how how do we do it? It just seems like we are up against hospitals, we're up against insurance companies, doctor schedules, and none of these things are conducive to women actually achieving a VBAC.
I wish I had an answer for that.
I'm always telling my doula clients to write letters to the hospital. Whether you had a great birth or a terrible birth, write a letter, because they need to know what is happening and how we feel about our births in the hospitals. And I'm just not sure that they're even being heard, even the ones that take the time to do it. And it just feels like the voice is so small.
It is.
It's a really, really tangled.
When I was a brand new midwife, I was told that the client, the paying customer, hospitals wouldn't exist if we didn't go in those doors. So I was told that the birthing woman has the power in that you can choose where you spend your money.
Exactly.
Hospitals are businesses. We just had this happen in Albuquerque. I was called a lot because I do water birth. How can we get water birth in the hospital? It's like, well, it's really tricky. You got to put a pool in every room. You can't just have 2 rooms, the good rooms over here, and if you're the third lady, you're just out of luck. Because people were going to the hospitals where they could use water for labor, if not birth itself. So it made a difference. Somebody finally woke up and said, we better offer water, because more patients or clients or customers are going to this other facility.
And
now, of course, it's gone downhill since then, because you have to have a water certified nurse on. You have to, so now the tubs are sitting empty, but it sounds good. It gets you through the front door. So
I guess one of the bigger questions is about insurance, and maybe it's malpractice insurance and the insurance that the hospital has to have, because it seems like they are driving the policy. And how can we even make a dent into their ear, so that they hear us?
You want the radical answer? Don't have insurance. Don't encourage them.
So I saw that we had one more question over here. We'll take that last question. Come on up.
Actually, that was my question. I wanted to ask Dr. Klose what we can do as community members, has birth support people and birthing women, what we can do to help you. Because I keep hearing how much your hands are tied a lot, and really sympathize with that. And I think that the film was a great way to bridge another aspect of social behavior. So in that respect, I think it was extremely successful. And we have these communities, the Birth Network, things that are rising up. But right here, right now in our community, what can we do to help you?
One thing that I've done over the years, I had a fair number of nurse midwives and patients that wanted to do home births. And what I have done in my practice is I've actually done a dual prenatal care with some of my patients with their option that they can do the home birth or they can do the hospital birth. And the thing that makes me nervous, if someone just wants to do a straight home birth and you say at 1% transport, that's great. I don't know what the numbers are here in Reno, but I think the fact that if you've got a midwife you're seeing, if you've seen an obstetrician, if something does happen, I'll tell you, to be on the receiving end of someone that you don't even know, has no prenatal record, no obstetrical care, whereas if she's been seeing the nurse midwife plus the obstetrician, and the patient rolls into labor and delivery, no matter who's on for me, covering for me, it's my patient still along with the nurse midwives, and so problems get resolved. So I've always found that to be a pretty interesting way of doing. Pardon? I've had some, I've had some community home birth. That's what you mean. Yeah. I mean, within our practice we have 2 nurse midwives, but I'm talking about the home births. And I can remember early on in my career, this one patient wanted a home birth, and she saw me, and she saw the nurse midwife, and I was actually on call. I got a call. She's been pushing for an hour and a half, and I think I ought to bring her in. And I said, hour and a half, that's nothing. yeah, just keep her pushing. And, you know, about an hour later, she delivered, and she ended up having two more home births after that. So I like the dual, you know, home birth, seeing the obstetrician. I think that's something that can be helpful. That's not what this meeting's about as far as the VBACs, but I like VBACs. I think they're great, but under controlled circumstances.
I think you're rare.
Oh, thank you.
You can tell he's rare because he's here.
Dr. Garcia and myself, Dr. Garcia is my partner. Because of the pregnancy center, we've birthed, each of us, between 13 and 14,000 babies. And we've had a heck of a lot of experience due to our experience through the pregnancy center. We're out of the pregnancy center for the last 2.5 years, and life is a little bit easier. But living in the hospital for 23 years, we were doing 400 to 500 deliveries per year, and I've seen it all. And so, thank you.
I would love to talk to all of you all night. I could do this. This is my dream, to do this all day long, every day.
Tiffany? Well, so I was going to say, do it again and invite an insurance representative.
And we will do this again.
And a hospital administrator.
And I wanted to thank Scott for, you spoke my mind. I had high hopes. I had hoped that this place would be packed to the rafters. And you expressed the frustration I deal with all the time. How do we make women care? And I don't know what the answer to that is. I guess we all have to just stick together and keep doing events like this and yeah, keep singing. I like the way you said that. So I'm just going to do a couple of closing remarks. I want to thank you to the speakers, especially Dr. Klose. I know you probably didn't know what you were walking into, and we are so thankful that you're in our community. You and Dr. Garcia and Lynn and Tammy, amazing practice. I wanted to remind you that there is a workshop tomorrow. We have a couple of spots available, so if you enjoyed what you heard this evening, most of the people on the panel are going to be presenting at a workshop tomorrow at Circus Circus. If you need any information, you can get a hold of me, either here tonight or by phone, 338-0755. And I want to remind you that if you liked what you heard, if you think this is helpful, if you want to see change happen in our community, the Birth Network, we're supported entirely by memberships, both professional memberships of mother-friendly birth professionals as well as consumers. And we would love to have you as a member. Out in the lobby, we have membership applications, as well as lots of information on VBAC and cesarean, lots of resources, because I know the film didn't give exact numbers. And so we have all of that information available out in the lobby. And our next free community class, we do monthly free community classes. And our next one is Monday, January 9th, and it's going to be called the 4th trimester, because we talk a lot about labor and birth and very little about what happens after you have the baby. So that will be our next class that we offer at the Hope Cafe. And I just wanted to thank everyone for coming. I, too, am grateful that those of you who decided to come and spend this many hours with us talking about birth, I appreciate it. So thank you.
Thank you, Tiffany.
And you're all free to go. Or stay and talk some more.